Good afternoon, dear students. Today we have a lecture. It is a new lecture from the new submodule. Previous lecture we finished submodule symptoms and signs of cardiovascular system disorders. The last lecture, if you remember, was about heart failure, and today we starting new submodule about respiratory system disorders. And first syndrome from your cycle of Propaedeutics of internal medicine will be about Bronchoobstructive Syndrome. It is a topic of our today's lecture. Before we start, let's discuss objective of our lecture. It is to coverage of modern concepts, the course and diagnostics of bronchial obstruction. And here you see a very interesting scheme. Yes, it is three main things, three main mechanisms that lie in the basis of bronchoobstruction. What is mechanism? It is emphysema with alveolar wall destruction and overinflation. It is chronic bronchitis like inflammatory component with productive cough and airway inflammation. And the third component, it is asthma. It is reversible obstruction of bronchi. The mechanisms that lie in the basis of asthma, it is bronchial hyperresponsiveness triggered by allergies, infections, etc. All of them lead to airway obstruction, especially small airway obstruction. And these main components, emphysema, chronic bronchitis, and asthma, build up in general syndrome of bronchoobstruction. Plan of our today's lecture, it is to give introduction of bronchoobstructive syndrome, discuss urgency and significance of problems of bronchoobstruction, discuss definition and causes, and we will talk about etiology, pathogenesis, as usual, symptoms and classification of bronchoobstructive syndrome, differential diagnosis, diagnostic tests, surveillance and prevention of bronchoobstructive syndrome. Introduction. What is bronchoobstructive syndrome? It is a pathological condition with airflow limitation during breathing. Approximately 100 heterogeneous diseases are associated with bronchoobstruction. In asthma and chronic obstructive pulmonary disease, it is leading clinical syndrome. Airway obstruction consists of reversible and irreversible components, with the inflammation as the main pathogenetic factor, developing under the influence of infections, allergic, physical, and neurogenic triggers. Moreover, the presence of viral and other respiratory infection deteriorates the course of bronchial obstruction, leading to the progression of the disease. In most cases, bronchoobstructive syndrome, its prognosis is serious and depends on the cause of bronchial obstruction, on the forms of the disease, and timely conducted pathogenetic therapy and prevention. What is the urgency of problem of bronchoobstruction? In childhood, respiratory disease occupy one of the first places in general morbidity in the world in pediatric practice. Hereditary factors, environmental pollution, social factors play an important role in it. In recent years, there has been a marked increase in disease that occur with an obstructive syndrome, especially in children, which is very diverse in nature and may be a manifestation of many diseases. Manifestation of the syndrome usually occurs on the background of acute respiratory viral infections. It takes a severe course and is accompanied by signs of respiratory failure. Early diagnosis of the disease that caused the obstruction, timely pathogenetic treatment, and prevention eliminates clinical manifestations of the syndrome and thus improve the quality of life of patients. What more problems and what more significant for broncho-obstruction? First of all, it is very often inadequate diagnosis. Yes, it has some difficulties in diagnosing and in general in diagnosis on broncho-obstruction and in differential diagnosis in causes. Is it more asthmatic component? Is it more inflammatory like bronchitis component? Or it can be COPD, like chronic obstructive pulmonary disease. Next problem, it is a lack of comprehensive program of monitoring of patients. These patients are very problematic. They are problematic in medical aspect, and they are problematic in social aspect. And general monitoring as medical as social, it is a really big problem in modern medicine. The lack of continuity of treatment in hospital and continuing treatment in an outpatient basis. All of these patients are treated during long time. During some acute period, it usually in hospital treatment. And this patient need a long treatment, years, months, years of continuing treatment, and it have to be the general scheme of the treatment of the patient. The hospital treatment can be continued in out-hospital treatment. That's why a general scheme must be present and must be keeping by doctors, and doctors in out-hospital doctors and in-hospital doctors have to be connected with each other in this scheme. The need for rehabilitation and social adaptation. I told that such patients are very problematic, and they need social adaptation, they need work adaptation. Okay, let's give definition. What is bronchoobstructive syndrome? It is a collective that includes a number of symptoms or clinical manifestations of bronchial obstruction with underlying narrowing or occlusion of the airway. Clinically, severe bronchoobstructive syndrome is most common in children, especially young children, but it's not a rare disease among the adult population. Its emergence and development is influenced by various factors, primarily respiratory viral infection. Early diagnosis and treatment of bronchoobstructive syndrome in therapeutic practice can significantly reduce the number of complications of the disease, improve survival and quality of life of patients. That's why timely diagnosed bronchoobstruction is very important for the patients. Okay, what more? Let's give one more definition. It is a little bit easier and more understandable. Bronchoobstruction, it is a complex of symptoms that develops due to limitation of air passing through narrowed airway or increasing of resistance against airflow during ventilation. And it shown on a picture at this slide. You see that it is narrowing of bronchi that lead to bronchoobstruction and abnormal airflow through these bronchi. In Western literature, these clinical symptoms complex and currently convincing, like Whistling syndrome. The term bronchoobstructive syndrome cannot be used as an independent diagnosis. It's not a disease, it can't be diagnosis. It is a syndrome that includes the number of different diseases. Bronchoobstructive syndrome, it is a symptom complex of any disease, the etiology of which is necessary to determine in all cases of the development of bronchial obstruction. Bronchoobstructive syndrome lays in a basis of asthma, bronchoectasis, bronchitis, chronic obstructive pulmonary disease or COPD, cystic fibrosis, etc. Another rare disease. Yes, one more time the picture from the first slide. Three main components. Yes, emphysema, asthma, and bronchitis. Causes of bronchoobstructive syndrome. Most often obstructive conditions occur in patients with a family history of allergies, especially who often suffer from respiratory infection, it more than 6 times per year. Smoking includes passive smoking, chronic obstructive pulmonary disease, serious asthma symptoms with frequent exacerbations for a long time which have not been improving with treatment. Long-term exposure to lung irritants, air pollution, industrial dust, chemical fumes, etc. Moreover, the causes can include preterm birth that leads to lung damage in neonatal chronic lung disease, a family history of emphysema, and inherited factors gene including alpha-1 antitrypsin deficiency. Okay, let's discuss a little bit etiology. It was the causes and in general etiological process. Acute stenosis laryngotracheal bronchitis of viral, bacterial, and viral etiology of diphtheria can be a cause of bronchoobstruction. It can be a peritonsillar abscess, retropharyngeal abscess, epiglottitis, a congenital stridor, hypertrophy of the tonsils and adenoids, cyst, hemangioma, and papillomatosis of the larynx. In infants, it is aspiration caused by swallowing disorders, congenital abnormalities of nasopharynx, chalasia and achalasia of esophagus, tracheobronchial fistula, gastroesophageal reflux disease. Malformations of trachea, bronchi, respiratory distress syndrome, cystic fibrosis, bronchopulmonary dysplasia, immunodeficiency, and intrauterine infection. The pathogenesis of bronchial obstruction. It depends on etiology of the disease. Pathogenetic mechanism can be divided into 2 main groups. First group, it is functional or reversible mechanism. It is bronchospasm, inflammatory infiltration, edema of the bronchi, violation of mucociliary clearance, and hypersecretion of mucus. And second group, it is irreversible pathogenetic mechanism. Here we can include congenital stenosis of bronchi and other irreversible changes. The main factor of pathogenesis of first group that are reversible is inflammation, which can be both infection and allergic, 2 types of inflammation or even their combination. The mediator of the acute phase of inflammation is interleukin-1. It is produced by phagocytic cells and tissue macrophages under the action of infection, allergy, and promote the release of first-type mediators like histamine, serotonin into peripheral blood. These mediators are constantly present in the granules of mast cells and basophils that ensures very rapid biological effects. Besides histamine, the important role of pathogenesis of inflammation is played by mediators of second type like eicosanoids, generated during the early inflammatory response. It is due to histamine, leukotrienes, and anti-inflammatory prostaglandins that were observed. Enhancement of vascular permeability, edema of bronchial mucosa, hypersecretion of mucus viscous, and bronchoconstriction. By duration, bronchoobstructive syndrome can be acute. It is bronchoobstruction syndrome clinical manifestation that persists for more than 10 days. It can be protracted, recurrent, and continuously recurring. According to the severity, the obstruction can be identified as mild, moderate, severe, and latent bronchial obstruction. It is a clinical form, clinical classification of bronchoobstructive syndrome. Common symptoms of bronchoobstructive syndrome. What the most often? It is prolonged exhale, wheezing, noisy breathing, like expiratory dyspnea, with respiratory rate 15 and more per minute. Asthmatic fits, auxiliary muscles participating in breathing, poorly productive cough, a decrease in oxygen partial pressure, depression and anxiety, weight loss, tiredness and fatigue, swollen ankles, limitations in activity and lifestyle. Okay, mild bronchoobstructive syndrome, you remember clinical forms. What are the most typical symptoms? It is wheezing on auscultation. It is no breathlessness and cyanosis at rest. Indices of blood gases are within the normal range. External respiration function, or ERF, indices are moderately reduced. State of health of the patient, as a rule, does not suffer. In moderate severity bronchoobstructive syndrome, expiratory or mixed dyspnea at rest will be present. It can be cyanosis of nasolabial triangle, intradural of compliant places of the chest, wheezing is audible at distance, and external respiratory function indices are reduced, but generalized function of bronchial obstruction is slightly broken. When partial pressure of oxygen is more than 60 millimeters Hg and partial pressure of CO2 is less than 45 millimeters Hg. Okay, severe course of bronchoobstructive syndrome. In state of health of the patient suffers, it is characterized by nausea, shortness of breath with auxiliary muscles participation. Presence of cyanosis, external respiratory function indices are sharply reduced, and there are signs of generalized functional bronchial obstruction with pressure of oxygen less than 60 millimeters Hg and pressure of bicarbonates more than 45 millimeters Hg. Okay, and it is a table with differential diagnosis of conditions of bronchoobstructive syndrome. What the most often conditions? It is chronic bronchitis. Here means obstructive bronchitis. It can be bronchoectasis, asthma, and bronchiolitis. It is subgroup of chronic bronchitis with obstruction of small bronchs that we named bronchioles. And main signs, it's understandable. For all previous, it is bronchus. For bronchiolitis, it is bronchial. What are the major changes? For chronic bronchitis, it is hyperplasia and hypersecretion of mucus glands. For bronchoectasis, the main mechanism, it is dilation and scarring of airways. For asthma, it is smooth muscle hyperplasia, excessive mucus, inflammation, and constriction of bronchi. And for bronchiolitis, it is inflammatory scarring and bronchial obliteration. What are the main causes? For chronic bronchitis and bronchiolitis, most often it is tobacco smoking and air pollutants. For bronchoectasis, it is persistent severe infections, and asthma usually immunological or idiopathic. And by the symptomatic, for chronic bronchitis, it is the most typical progressive cough. For bronchiolitis, cough and dyspnea. For bronchoectasis, cough, purulent sputum and fever. And for asthma, episodic wheezing, cough and dyspnea. Okay, what's the difference in condition of bronchoobstructive syndrome? In asthma, the bronchial tubes that we name airways are hyperresponsive and usually are triggered by breathing in things in the air such as dust, pollen, etc., with a recurring episode of wheezing, breathlessness, chest tightness, and coughing, particularly at night or in early morning. Bronchoectasis, it refers to abnormal, irreversible dilation of bronchi caused by destructive and inflammatory changes in the airway walls. The opposite, the chronic obstructive pulmonary disease, is characterized by airflow limitation that is not fully reversible or irreversible at all. And the most often forms, it is COPD, chronic obstruction pulmonary disease, and asthma. What is the difference between them? For COPD, it is onset in midlife. For asthma, it is onset in early life, most often in childhood. For COPD, symptoms slowly progressive. For asthma, symptoms usually vary from day to day, and it is typical symptoms at night and early morning. For COPD, typical long smoking history, dyspnea during exercise. For asthma, it's typical allergy, rhinitis, or eczema. And for asthma, it's more typical family history, cases of asthma in nearest relative. And one more difference, that for COPD, it is largely irreversible airflow limitation, and for asthma, it is mostly reversible airflow limitation. To confirm presence of bronchoobstruction and differential diagnosis between different disorders, we used functional tests. The most usable of them we name spirometry. How it looks like you see on the picture. It is one type of pulmonary function test. Spirometry, it is a simple test to measure how much volume and how fast by the floor you can move air into and out of your lungs. Okay, and what the result? Usually, for example, today you blew out 3.1 liters of air in 1 second. There is about much air as would fit in 1.5 2-liter bottles of soda. You see? You imagine nearly how much air you can blow out in one time. Men should be able to blow out at least 4.3 liters of air in 1 second. And decreasement of this volume or decreasement of the airflow say us about bronchoobstruction. And results look like this. In graphically, we see that it is a volume of air that patient able to blow out. Yes, first picture, it is a spirometry of healthy patient, and according to this graphic, we can calculate several signs, like the most important of them. It is first vital capacity of FVC, first expiratory volume in first second of expiration, or FEV1, and relation between them, between FVC and FEV1. And according to results of spirometry and FEV1 and FVC, we can classify bronchoobstruction. And let's look at on an example of classification of one of the most often and maybe the most serious disorder, like COPD. COPD classify on 4 stages. It is mild, moderate, severe, and very severe stages, and we name this classification GOLD classification. GOLD 1, from GOLD 1 to GOLD 4. GOLD 1, it is mild stage of COPD when it is preserved as expiratory volume in 1 second as a relation with forced vital capacity. Goal 2, it is moderate when expiratory volume in first second we get from 50 to 80%. Severe or gold 3 when forced expiratory volume in first second in spirometry will be from 30 to 50%, and gold 4 when forced expiratory volume in first second less than 30%. And for gold 2, 3, and 4, a relation between FEV1 and FVC less than 0.7. Okay, diagnostic function test. What more we can use for diagnosing of bronchoobstruction? The floor volume loop is a plot respiratory, inspiratory and expiratory flow by the y-axis against volume by the x-axis during performance of maximally forced inspiratory and expiratory maneuvers. The patient is instructed to take a full inspiration to total lung capacity. Exhale forcefully and completely into the mouthpiece to residual volume, and then inspire forcefully and fully back to the total lung capacity. Typically, a flow volume loop needs to request specifically as an order of spirometry frequently yields just an expiratory portion. Okay, on practical classes, please stop with your teachers on the things and try to image, and maybe try even without the spirometer. You can take some tube and practice all these maneuvers for spirometry. The normal expiratory portion of the flow volume curve is characterized by a rapid rise to the peak flow rate, followed by nearly linear fall in the flow as patient exhales toward residual volume. The inspiratory curve, in contrast, is a relatively symmetrical saddle-shaped curve. The flow rate in the midpoint of vital capacity between total lung capacity and residual volume, known as a forced expiratory flow 15 or FEV15, is a normally slightly less than flow rate in the midpoint of inspiration, known as the forced inspiratory flow 15, FIF15. Thus, the ratio between FEF50 and FIF50 is normally less than 1. Here you see how looks like their loops. Yes, first picture, it is a normal person, young person, aged 20 years. Second picture, mild obstruction. Next one, severe obstruction. And next one, it is variable extrathoracic stenosis, where you see that form of loops is preserved by the volume is decreased. Lower row of the picture. On the first lower picture, you see the normal loop too, but it is a little bit different in a higher age. It is example for patient 15 years old, 50 years old. Next picture, it is moderate and severe obstruction, like for example in asthma in acute stage or COPD patient. Next picture, you see how looks the loop in patient with pulmonary fibrosis. It is restrictive type. And for patient older with variable intrathoracic stenosis, you see that it is changed form of the loop. Moreover, we can use another diagnostic test. We usually do for such patients the X-rays. The chest X-ray can detect cancer, infection of air collecting in the space around a lung, which can cause a lung to collapse. They can also show chronic lung conditions such as emphysema or cystic fibrosis, as well as complications related to these conditions. And you see pictures with examples of positive chest radiographs for the indication of chest pain, accounting for approximately 12 of the total exams performed. You see how it looks like. First picture, it is pneumothorax. Next one, it is round pneumonia, and third one, it is perihilar inflammation. Okay, next slide. More we can use arterial blood gas. Arterial blood gas, it is a blood test measures the acidity or pH and levels of oxygen O2 or carbon dioxide CO2 from an artery. The test is used to check the function of patients' lungs and how well they are able to move oxygen into the blood and remove carbon dioxide. This test is commonly performed in the ICU and ER setting. However, arterial blood gases can be drawn as any patient or any flow depending on their diagnosis. Okay, and values of arterial blood gases. Normal pH is from 7.35 to 7.45. Less than these numbers, it is acidosis. More than these numbers means alkalosis. Pressure of oxygen. Normally, it have to be more than 90% millimeters hydroargum. Sorry. From 75 to 89, it is mild hypoxia. Less than 75, severe hypoxia. Pressure of carbon dioxide normally have to be from 35 till 45. Less than 35, it is alkalosis. More than 45, it is acidosis. And pressure of CO3 have to be from 18 to 24 milliequals per liter. Less than this number, acidosis. Higher than these numbers, alkalosis. Okay, pressure of carbon dioxide in millimeters hydroargum or kilopascals indicates the effectiveness of alveolar ventilation. Alveolar ventilation determines pressure of carbon dioxide. Hyperventilation results in a decrease of pressure of carbon dioxide. We name it hypocapnia, whereas hypoventilation increased pressure of carbon dioxide, and we name it hypercapnia. Changes in ventilation may occur in patients with primary pulmonary disease, central nervous system impairment, or may occur as a compensatory change in patients with metabolic disturbances. Okay, the most simple method to measure saturation or pressure of oxygen we named pulse oximetry. And device that we use for it, pulse oximeter. Maybe everyone during pandemic see this device. It looks like something small that fixed on a finger and can check saturation pressure of oxygen in capillary blood. It measures percentage of hemoglobin actually carrying oxygen. In normal, it have to be from 95 till 100%. The test can be useful to finding out whereas oxygen treatment is needed, but it provides less information than arterial blood gas test, but it is much less expensive. It is cheaper, quicker, and non-invasive. And interpretation of pulse oximetry you see in a small table in left part of this slide, that you see that more than 95 it is normal saturation. From 91 to 94 it is you see that it have to be some management. From 85 till 90 it is moderate severity hypoxia, and you see management, and less than 85 it is a very severe hypoxia. Okay, let's compare arterial blood gas analysis and oximetry. Yes, arterial blood gases, invasive, pulse oximetry, non-invasive. For arterial blood gases, result delayed, and for pulse oximetry, results are immediate. Access intermediate. For pulse oximetry, assessment can be continuous. For arterial blood gases, accesses oxygenation, ventilation, and acid-base status. Here it checks just oxygenation. For arterial blood gases, corrections routinely made for hyper and hypothermia, and for pulse oximetry it is impossible that results misleading in the presence of alkalosis, hyper and hypothermia, carboxyhemoglobin, and other factors. Accuracy established for arterial blood gases, and in some clinical settings uncertain for pulse oximetry. And it is more expensive for arterial blood gases and less expensive for pulse oximetry. But you see here question, why question? Because if, for example, patient buying pulse oximeter for individual checking, just for one patient, not in hospital test, for example, for home monitoring, of course it is not less expensive than one checking of arterial blood gases. Okay, electrocardiogram features. We usually do ECG and find their changes in patients with chronic obstructive pulmonary disease. It is present of hyper-explained emphysematous lungs within the chest. The long-term effects of hypoxic pulmonary vasoconstriction upon the right side of the heart, causing pulmonary hypertension and subsequent right atrial and right ventricular hypertrophy. We name it cor pulmonale, that we can see on ECG. Here an example of ECG demonstrates many of the features of chronic pulmonary disease. First of all, it is rightward QRS axis. It is peaked P waves in the inferior leads. You remember it is AVF third. More than 2.5 millimeters. We name it P pulmonale with a rightward P wave axis inverted in AVL. Moreover, we can see on this ECG clockwise rotation of the heart with a delayed RS transposition point. It is absence of R waves in the right precordial leads SV1, V2, V3 pattern, and low voltages in the left-sided leads 1, AVL, V5, V6. Who are interested in, please stop on the video on this ECG and trying to analyze for yourself all these signs. It is a classical clinical picture of cor pulmonale and other changes that typical for COPD. It is one more ECG. It shows multifocal atrial tachycardia with additional features of COPD. It is arrhythmia plus cor pulmonale. Here we can see rapid irregular rhythm with multiple P-wave morphologies. Best seen you can in rhythm strip, which is a lower strip, usually it's second, that contains longer recording of one lead. Moreover, here right axis deviation, dominant R wave in V1 and deep S in V6 suggest right ventricular hypertrophy due to cor pulmonale. Okay, one more diagnostic tool for us, it is diffusing capacity of the lungs. A test of the diffusing capacity of the lungs for carbon monoxide, DLCO, also known as a transfer factor for carbon monoxide, or TLCO, is one of the most clinically valuable tests for lung function. The DLCO measures the ability of the lungs to transfer gas from inhaled air to red blood cells in the pulmonary capillaries. The DLCO test is convenient and easy to patient to perform. The 10 seconds of the breath holding required for diffuse capacity of lungs carbon monoxide maneuver is easier for most patients to perform than the first exhalation required for spirometry. The following division is frequently employed in clinical practice for assessment of reduction of transferred factor. In normal, it more than 75% of predicted up to 140, mild decrease from 60 to 74, moderate decrease from 40 to 59, and severe decrease less than 40%. Computer tomography of the lungs, additionally, in some cases, can be used for visualization of lungs. It allows for early detection of emphysema. CT also makes it possible to quantify a total amount of emphysema in the lungs, which is important to order precisely estimate the severity of the disease. You understand that it is the most important in emphysema patients. Those ability of CT are important in monitoring the cause of the disease, and it attempts to prevent its further progression. Okay, surveillance and prevention of bronchoobstructive syndrome. National surveillance systems should primarily focus on monitoring the following bearing in the mind of importance and developing the implementing simple methodologies for providing objective measures of trends. It causes specific mortality, risk factor prevalence, certain morbidity data like hospital admissions and consultations due to common respiratory conditions, as well as therapeutic trends. Standard indications should be adopted. These may include lung function measurements, disease progression, absenteeism for school or work, and hospitalizations. And you see scheme of primary prevention. It needed reduction or avoidance of personal exposure to primary risk factors to be studied during pregnancy and childhood. Yes, and you see the main way of prevention. And secondary prevention, it more complex. It when the bronchoobstruction is present, we prevent further worsening and further progression of different disorders, and first of all, prevention of COPD. Yes, it lies in early detection of occupational asthma, early detection of COPD, and possible prevention of COPD with smoking cessation, pulmonary rehabilitation, reduction of exposure irritants, influenza vaccination, and more another mechanisms of prevention of COPD and bronchoobstruction in general. Okay, for today that's all. It's everything, all main things that I want to tell you about bronchoobstructive syndrome. More information I left for your self-work and for your practical classes. And as usual, if you have questions, if you have comments, please leave them in the comments under this YouTube video or in our closed Facebook page in our department under this video too. And I'm waiting for your names and for your groups in comments under the video. For today that's all. Goodbye.